So let's start. I hope uh, this class we meet again after a gap of 1.5 months, and now we will be discussing straight on things that are more practically useful in the final professional examination, because the final professional examination is tentatively happening probably in the next month. At the end of next month it will start. So we are going to discuss today regarding a topic on medicine, that is respiratory system. But the only things that are important in the structured oral examination, that is the SOE examination of the final prof. So we are not going to discuss in detail about anything, but still, if anyone have any query, because within our very limited time, it is very difficult to cover everything. Uh, Still, I have decided to make 2 classes on the oral examinations of the respiratory system. This is the first, so we will have another class hopefully on the next week. But still, if someone still have any query regarding anything, please give it in the message. So I will try to answer after completing the class. I will try to reply your queries. But I will ask everybody to limit your queries uh, not within the area of the final professional examination. That will make things easier. So the oral examination actually is very important. In the final prof, this rarely happens that someone fails in OSPE. The reason I will not going to reveal, and it's more rare to fail in the written part. So failure usually happens in the oral part and the clinical part, mainly in the clinical part. But still, oral examination is very important in that sense that it occurs before the clinical examination. So first the oral examination happens, and thereafter the clinical part starts with long case and finally the short case. This is the usual norm. So if someone creates a very bad impression in the oral board, he or she will definitely face the same people in either the short case or in the long case. So a very bad impression in the oral board will ultimately create a bad impression from the very beginning of the crossing or presentation of the clinical part. That is why oral examination is very important. And I have my tricks in oral examination. That is, in oral examination, it is not going to be counted that how well you say, how much deep you know. But the more main thing that counts is how less amount of mistakes you make. So my suggestion is to speak less. The dumb has always fewer number of enemies. So please try to speak less. Try to answer to the point. Don't talk too much, and don't give absurd answers when you do not know it actually. Politely say that I cannot recall right now. So the examiner may go into another question. But if you give a very uh, totally different answer from what is asked, and it creates your impression in a very bad way. So let's start with, usually the oral examination, we have 3 boards, one with pediatrics, that's a different story. So we have 2 boards in the internal medicine, and the 2 boards usually for the new curriculum, the 2 boards starts with either X-ray or ECG. So it is very much expected that in one board, the examination is going to start with chest X-ray. So the questions from the respiratory system uh, is usually starts after reading the given X-ray. But sometimes there are other occasions when questions may arise from giving a scenario. So that will be discussed too. But the main way the examiners get into the respiratory system is by getting through the X-rays. So it is very important that you read out the X-ray given at the beginning of your examination very confidently. It gives a very good impression. So the rest of the examination will go on smoothly if you can read the given X-ray properly. So to start with, just I know that it's very much common thing. You should know this. That is how to read an X-ray. It is very easy. That is at first, when you are going to read the X-ray, you should say that this is an X-ray chest, posterior anterior view. Please don't use the term PA view. Don't use such short forms. So this is an X-ray chest, posterior anterior view. Then tell the positive findings, and finally tell other findings which are normal. This is the usual way. Okay. Another thing is what we look for. We look for these things. That is mainly the abnormalities in the lungs, the costo and cardiophrenic angles, the position of trachea, and in cardiac X-rays, that is, those are also chest X-rays. I am not going to discuss these cardiac X-rays today, but heart and pulmonary vessels are important. The bony thorax and soft tissues, these X-rays are not usually given. Abnormal X-rays are not usually given in final professional examination. But still you have to tell that these are normal. So in most of the occasions, it's likely that you give the description of the abnormality in the lung fields, and then you tell that the other features, obviously naming the features separately, like cardiac shadow, the cardiophrenic costophenic angles, the pulmonary vessels, the trachea, the bony thorax, and the soft tissue shadows. These are normal. So this is the way. Okay. Another thing is when you are describing an abnormality in the lung fields, you have to say that how does it look and where it is located. So how does it look means whether it is homogeneous, whether it is non-homogeneous, whether it is patchy. There is another term called patchy. Whether it has a very particular shape. Some features, some lesions have particular rounded shape. So this is one thing, the appearance, and another thing is location. So the location means which lung it is located and which part of that particular lung it is located. So in description of the location, we use the term zone. So please remember, the zone does not mean the lobe. So upper zone is not the upper lobe, mid zone is not the middle lobe, and lower zone is not the lower lobe. In fact, these are arbitrary areas in the chest X-ray that divides the lung fields. So in the upper zone, it is not sure that anything in the upper zone are located actually in the upper lobe. The lower lobe also occupies some part of the upper zones because there is an oblique fissure. There are so many overlaps from anterior posterior view. So this is zone. This is not the lobe. Please remember it. But during the description, you have to tell which zone is involved in the lesion. So that is why I am telling. That is, the upper zone means a horizontal line from the anterior part of the second rib, that is this one. Anything above it is upper zone. And another horizontal line from the anterior end of the fourth rib, that is 1, 2, 3, and 4. This is the anterior end. These are posterior ends. Okay. So this is the anterior 1, 2, 3, and 4. So this line below this second line, the lower line, everything is in the lower zone. And in between these two lines, everything is in the mid zone. So this is upper zone, lower mid zone, and lower zone of the lung fields. Remember, this is not upper lobe, this is not middle lobe, this is not lower lobe. This is only the radiological zones. Okay. So don't get confused with these things. So let's straight get into the first case. Look at this X-ray. What does it show? So it shows clearly that there is some abnormality in the right side of the chest. So how does it look? If you look at it carefully, the abnormality, there is an opacity. Okay. And this opacity is that much opaque that it is almost equal to the opacity of the heart. So such kind of opacities are called dense homogeneous opacities. So the opacity is equally dense, equally opaque in all its parts, so it is homogeneous, and the density is equal to that of heart. So it is called dense homogeneous opacity. Another thing you can see that there is an upper border which is concave, crescentic. Okay, so such dense homogeneous opacities with a crescentic border in the lower part of the lungs, which obliterates the costophrenic and the cardiophrenic angles of the same side. Just look at this. This is the costophrenic angle, the angle between the diaphragm and the chest wall. And this is the cardiophrenic angle, the angle between the heart and the diaphragm. So these angles are very clear in the left side, but in the right side, because of this lesion, we cannot see these angles. So if you summarize the description, there is a dense homogeneous opacity in the lower zone of the right lung field with crescentic upper border, obliterating the right costophrenic and cardiophrenic angles. There is a dense homogeneous opacity in the right lower zone, okay, or lower zone of the right lung with crescentic upper border, obliterating the right costophrenic and cardiophrenic angles. Okay. So this is the description. This is an X-ray chest, posterior anterior view, showing dense homogeneous opacity in the lower zone of right lung field with crescentic upper border, obliterating the right costophrenic and cardiophrenic angles. Then tell the normal things, that is, trachea is central, cardiac shadow, pulmonary vessels, bony thorax and soft tissue shadows are normal, as we said. So then you tell that my radiological diagnosis is right-sided pleural effusion. Very simple, right-sided pleural effusion. So this is an X-ray that shows and right-sided pleural effusion. So if you can confidently start your examination like this is an X-ray chest, posterior anterior view, showing a dense homogeneous opacity in the lower part or the lower zone of the right lung field with a crescentic upper margin, obliterating right costophrenic and cardiophrenic angles. The trachea is central. The heart shadow, the pulmonary vessels, the bony thorax, and the soft tissue shadows are normal. My radiological diagnosis is right-sided pleural effusion. So you have to tell it slowly and clearly. So with this, your examination actually starts, and actually it looks like a smooth start. So the next question will be, what is pleural effusion? If they are asked, you just tell that abnormal accumulation or excessive accumulation of fluid in the pleural cavity is called pleural effusion. And then they may ask you, so does pleural sac contain any fluid normally? You can smoothly answer that yes, normally it contain 10 to 12, 20 milliliter of fluid, but when it is more than that, it is called a pleural effusion. So you may be asked, when the X-ray is still on the view board, you can still be asked, so how much pleural fluid this patient may have. That means to be detected in X-ray, how much pleural fluid should be there in an effusion. So the amount pleural effusion should be at least 200 ml if you want to see it in the conventional posterior anterior view of the chest X-ray. So your answer will be 200 ml fluid, pleural fluid is minimally required to be visualized in conventional posterior anterior view chest X-ray. So if someone has pleural effusion less than this amount, is there any way to detect it? Of course, there are ways. There are 3 ways you can detect lesser amount of pleural fluid. And so these are step-by-step questions. Okay, I'm just telling this. This is one is chest X-ray in lateral decubes. That means if someone has right-sided pleural effusion, the chest X-ray will be taken when the patient lies down on right lateral decubitus. If it is in the left-sided pleural effusion, the chest X-ray will be taken when the patient lies down in left lateral decubitus. So this is the lateral decubitus view. It can detect even 100 or 50 ml of fluid. Okay. Another thing is ultrasonogram of chest and finally CT scan of chest. So If someone has less than 200 ml of fluid in the pleural cavity, it can be detected. It may be missed in conventional chest X-ray posterior anterior view, but it can be detected in chest X-ray in lateral decubitus position, ultrasonogram of chest, or CT scan of chest. So how much fluid is required for a pleural effusion to be detected by clinical examination? In fact, X-ray can detect 200 ml, not less than that. But still, if you want to detect it by examining the patient, you need more fluid, and that is 500 ml. So these are very popular questions when you are given an X-ray of the pleural effusion. It is how much needed to be detected clinically, how much needed to be detected with conventional X-ray, and what to do if less amount of fluid is there. So it's very easy. Is 500 ml is required to be detected by clinical exam. 200 ml is required to be detected by conventional posterior anterior chest X-ray. And if the amount is less, then what you can do, you can go for any of the three options. Chest X-ray in lateral decubitus view, lateral decubitus, and ultrasonogram of chest, finally CT scan of chest. So as your convenience, you can do any of these three. So let's get back into this patient. That is, our patient had right-sided pleural effusion. What symptoms the patient may have? Remember, for pleural effusion, the common symptom is shortness of breath. Okay? But if the effusion is not much, the patient may be totally asymptomatic. But commonly, the patients of such kind of small pleural effusions, moderate pleural effusion, usually presents with a feeling of heaviness in the affected chest. So as this patient has right-sided pleural effusion, he may have shortness of breath or may have a feeling of heaviness in the right chest. So what you will find if the patient is examined? The expected signs, these are very common things, but you should recall it, or you should practice it in such a way that you do not make a single mistakes while describing. Okay, so for convenience, just tell that this is a right-sided pleural effusion. So when I will examine the chest, I will find the following things in the right side. That is, on inspection, the movement of the chest will be restricted. On palpation, the chest expansion will be reduced. The focal meters will be absent. On percussion, the percussion note will be dull. And on auscultation, breath sound will be absent, vocal rudiments will be absent. So these are the simple things. Remember, uh, if you just carefully look at this particular X-ray, the trachea is central in this X-ray. So there is no pressure effect of this pleural effusion. So while you will examine this patient, the trachea will be central. So as the trachea is central is very normal finding, you don't have to mention it in the examination thing. Okay. So we are often taught that pleural effusion causes shifting of the trachea to the opposite side, but it's not always present. Only a very big amount of pleural effusion can cause it. So here the amount of fluid is not big enough to push the trachea, and it is clearly visible centrally in this X-ray. So in this patient, don't tell while asked about the signs that trachea is shifted to the left. Okay, so this kind of mistakes usually happen. You are given an X-ray, you are looking at the X-ray, and trachea is clearly visible at the center, and while describing you say that trachea is shifted to the opposite side. So this kind of silly mistakes should not happen. Okay, keep your head cool and describe as the chest X-ray is showing. Okay. So in this patient, don't tell that the trachea is shifted to the left. Tell about the trachea. It is central. It is central. Okay. So what are the causes of this pleural effusion in this patient? So whenever someone has unilateral pleural effusion, you have only three causes to remember. Common. One is tuberculosis, another is pneumonia, and another one is bronchial carcinoma. So tuberculosis, pneumonia, bronchial carcinoma. Causes of unilateral pleural effusion are three. That is tuberculosis, pneumonia and bronchial carcinoma. Remember, don't use the term pulmonary tuberculosis here, because this is not pulmonary tuberculosis, this is pleural tuberculosis. And pleural tuberculosis is an extra pulmonary tuberculosis. This is not pulmonary tuberculosis. It can be as a uh, can occur in addition to pulmonary tuberculosis. That's a different thing. But only tuberculosis causing pleural effusion is not pulmonary. So this is extra pulmonary. So better use the term tuberculosis. Do not use pulmonary before it. Okay, fine. So can you guess that then the examiner may ask you, can you guess whether this is tubercular, pneumonic or malignant from the history? So your answer will be, yes, I can guess. I can guess. Not impossible, but I can guess. So if there is a very short history of high fever, productive cough with purulent sputum and right-sided chest pain, in this patient the lesion is on the right side, it is pneumonia. So if there is a long history of low-grade fever with evening rise of temperature, weight loss, uh, this will suggest tuberculosis. And if the history gives uh, features of weight loss, hemoptysis, chest pain, in elderly smoker, the likely cause is bronchial carcinoma. So it is not foolproof, but still from the history you can guess. So very short history of high fever, purulent sputum, chest pain, pneumonia. Long history of low-grade fever with evening rise of temperature and weight loss, tuberculosis. And in an elderly smoker who also have weight loss and hemoptysis, always think about the malignancy. So now what investigations, other investigations you want to do in this patient? So you still have the X-ray in the view board and your viva is going on, oral exam is going on. So you just tell that complete blood count with ESR and pleural fluid analysis. Uh, yeah, actually complete blood count includes the uh, test ESR. But there are quite a few examiners I actually encountered when I was an examiner in different examinations, that many examiners love the term that full blood count with ESR, complete blood count with ESR. So if you tell it, that's not a problem. So better, most of the examiners like the term complete blood count with ESR, is it? So how the, then you will be asked, so what is the utility of complete blood count and ESR in the diagnosis of pleural effusion? Okay, it is not straightforward diagnostic of the cause, but still there are some clues. Okay, for example, if there is polymorphonuclear leukocytosis, the likely cause is pneumonia. If the ESR is very high, then the likely cause is either tuberculosis or bronchial carcinoma. So CBC ESR can help, but the ultimate diagnosis will be made with the help of analysis of the pleural fluid. So what tests usually are done? Commonly, these things are done on pleural fluid, that is the physical appearance, the biochemical test. There are a lot of biochemical tests. Only two have to be mentioned, that is the albumin and ADA. ADA means this is an enzyme, that is adenosine deaminase. Then the cytological examination, uh, we will look for the different WBCs and also for malignant cells. Finally, the microbiological examination. Usually you will look for acid fast bacilli, and we also do the test gene expert, is a PCR test to detect tubercular bacilli. So we will discuss about gene expert when we will discuss about the tuberculosis, but uh, your answer should be very specific. In pleural fluid analysis, we look at the pleural fluid for appearance. We do biochemical tests, most importantly albumin and ADA. We do cytological examination, look for the WBCs and the malignant cells, and finally we do microbiological tests, most importantly AFP and gene expert. So During drawing the pleural fluid, aspirate doing the aspiration of pleural fluid, you will see the color. So does it have any significance? Yes, of course, the color you can give you a clue to the cause. If the pleural fluid is straw color, then the likely cause is tuberculosis. And if the pleural fluid is red, that is hemorrhagic, the likely cause is bronchial clot. So the color is very important. It is a very common question in the final prof. So what importance is there for the biochemical test of the pleural fluid? So I have already said we do two tests. One is albumin, or one is adenosine deaminase or ADA. So albumin means if albumin is more than 30 gram per liter, it indicates exudative effusion. So we will be discussing regarding the exudative and other type of pathological type of effusions. If the albumin is less than 25 gram per liter, it indicates transudative pleural effusion. So the exudative and transudative pleural effusions are totally different mechanisms, totally different and totally different further investigations for detection. And more than more important than this albumin is ADA. High level of a rise of ADA in the pleural fluid usually indicates tuberculosis. So sometimes we forget to tell ADA, so please don't forget. Okay. So how does the cytological features help in differentiating the causes? It is also important. If the predominant cells are neutrophils, that is the polymorphs, then probably this is pneumonia related pleural effusion, parapneumonic pleural effusion. If the main cells are lymphocytes, then it is likely to be tubercular pleural effusion. And if you can see the malignant cells, then it is likely to be bronchial carcinoma. So you may be asked directly that what are the features of the pleural fluid in a tuberculous pleural effusion. So straightforward, the pleural fluid will look straw. There will be high albumin and high ADA. There will be increased number of lymphocytes in the pleural fluid. And finally, the pleural fluid, if examined for acid fast bacilli or with gene expert, it will yield positive result. So what are the features of a malignant pleural effusion? Uh, First of all, it is hemorrhagic. The albumin will be high, more than 30 gram per liter, and malignant cells will be seen on cytology. So let's get into our second case. Just look at it. Okay. What we see here, uh, there is an opacity, and it is actually occupying the lower, mid, and the upper zones. So all the zones are occupied by this. Zones of the left lung are occupied by this opacity. If you see it, the opacity have the same density of the heart. So this is a dense homogeneous opacity in the all zones of the left side. And the left cardiophrenic and costophrenic angles are not visible. So it is obliterating both left cardiophrenic and costophrenic angles. However, there is no crescentic upper margin. It is because the opacity is so big that it is occupying the entire left lung. So there is no upper margin of the opacities. So there is no crescentic upper margin. When you cannot get the upper margin, how can you get the crescentic upper margin? The interesting thing here is, look at the trachea. The trachea is shifted to the right side. So as if this thing, this lesion is pushing the trachea to the opposite side. So let's describe it. There is a dense homogeneous opacity in all zones of the left lung, obliterating left costophrenic and cardiophrenic angles, and trachea is shifted to the right side. Cardiac shadow, pulmonary vessels, ponithorax, soft tissue shadows are normal. So my radiological diagnosis is left-sided massive pleural effusion. So when a pleural effusion shifts the mediastinum to the opposite side, it should be a massive pleural effusion. Okay, so this is a big one. Usually 4 liters of fluid are minimally required. At least 4 liters of fluid should be accumulated before a pleural effusion is such massive to push the mediastinum, that includes the heart and the trachea, towards the opposite side. Okay, fine. So this is left-sided massive pleural effusion. So this patient will present with respiratory distress. That means there is severe form of shortness of breath. So what signs you expect in this case? In this case, the description is almost similar to the previous one, but this time you say that changes will be in the left side. So same thing, and put the shifted trachea here. That is, on palpation, the trachea is shifted to the right side, because in the X-ray, the trachea is shifted to the right side. So when you examine the patient, you expect the trachea to be in the right side. So when in Viva board you are asked, so what will be the signs in this patient? Don't forget to correlate the position of trachea of the X-ray with description. If the trachea is central in the X-ray, tell the trachea is central. If the trachea is shifted to the opposite side in the X-ray, don't forget to mention the trachea is shifted to the opposite side. Okay. So this is the description just like the previous one, but on the left side. And one thing I have added, that is the trachea is shifted to the right. Okay. Same thing for pleural effusion. So how will you treat this patient? In this patient, the treatment actually we have two things. One is therapeutic pleural fluid aspiration. That means as the patient has severe shortness of breath, severe dyspnea right now, you have to relieve the dyspnea by withdrawing the fluid from the pleural cavity, by releasing the pressure. One thing. Another thing is treatment of the cause. So if it is tubercular, give anti-TB drugs. If it is malignant, consult the oncologist for proper treatment according to the stage of the malignancy. If it is parapneumonic, treat the pneumonia with proper antibiotics. All like that. Treatment of the cause. But the very important thing in this massive pleural effusion is you have to aspirate to release the pressure from the pleural cavity so that the patient becomes normal. Patient is relieved from the dyspnea. Fine. So what are the indications of pleural fluid aspiration? In all cases of pleural effusions, unilateral pleural effusions, pleural fluid is aspirated for diagnostic purpose. That is, pleural fluid analysis is an essential part of the examination of the investigation of the pleural effusion. But there are some other indications. That is, in massive pleural effusion, you have to draw a very large amount of fluid to relieve the patient from dyspnea. So there are two indications. One is diagnostic, which is done in all cases of unilateral pleural effusion, and also therapeutic, which is done only in massive pleural effusions. So let's get another case, look at it. In this patient, there are two opacities, one in the right side, one in the left side. So in the lower zone of right and left sides, we have two opacities. The opacities are dense homogeneous. That is, the opacities has the density same as that of heart. So these are dense homogeneous opacities in the lower zones of both lung fields. And both cardiophrenic and costophrenic angles are obliterated. Trachea is central. The heart shadow, as far as visible, is normal. Pulmonary vessels, the bony thorax, and the soft tissue shadows are normal. So your diagnosis will be, in this case, bilateral pleural effusion. So dense homogeneous opacities in the lower zones of both lung fields with crescentic upper borders. Both costophrenic and cardiophrenic angles are obliterated. Trachea is central. Then just like the previous things. So my radiological diagnosis is bilateral pleural effusion. So this is bilateral pleural effusion. So what are the probable cause of bilateral pleural effusion? That means here in this patient. Actually, the causes of bilateral pleural effusion are totally different from the causes of unilateral pleural effusion. And these are heart failure, nephrotic syndrome, and chronic liver disease, cirrhosis of liver. So this is these are the causes of bilateral pleural effusion. So these causes are called transudative causes. So you may be asked that what is exudative and what is transudative. If you use the term transudative, then definitely they will ask you what do you mean by transudative, what is the other term. You can then tell it is exudative. So you will be asked what do you mean by exudative, what do you mean by transudative. So these are the unilateral pleural effusions, exudative, that is tuberculosis, pneumonia, and bronchial carcinoma. So then you will be asked, what do you mean by exudative and transudative? Exudative means that the fluid comes out of the vessels due to increased permeability. And most commonly it happens in inflammatory conditions like pneumonia and tuberculosis. Okay. So this is due to increased permeability of the vessels. Okay. So the vessel permeability is increased. The vessel wall is damaged. On the other hand, in transudative, the vessel wall is normal, but the forces that controls the movement of fluid from the tissue space into the vessel, that is the vascular hydrostatic pressure, the vascular colloidal osmotic pressure, and tissue colloidal osmotic pressure. If there is an imbalance among these three, it will cause shift of the fluid from vessel into the tissues. So this is called transudative effusion. For example, in heart failure, the main problem is increase in colloidal osmotic pressure, increase in hydrostatic pressure. In nephrotic syndrome and in CLD, the main problem is decrease in colloidal osmotic pressure. So this thing happens. So there is no problem in the vessel wall permeability. Vessel wall is normal. There is not more permeable to the fluids, but the fluid is still shifting out of the vessel into the tissues because of the imbalance between the imbalance among the different forces that controls the movement of fluid across the vessel wall. So there is no problem in the vessel wall itself. This is transudative. Usually, exudative pleural effusions are unilateral, and transudative pleural effusions, as these are generalized disorders like heart failure, nephrotic syndrome, or chronic liver disease, uh, the effusions are bilateral. So can pleural fluid study help by this, in distinguishing between pleural effusions, whether they are exudative, transudative? Yes, of course. If the pleural fluid albumin count is more than albumin concentration is more than 30 gram per liter, it is likely to be exudative. If it is less than 25 gram per liter, it is likely to be transudative. Another thing is if there are too many cells, particularly WBCs or malignant cells in the effusion fluid, then it is likely to be exudative. And if there are no cells, then it is likely to be transudative. So what investigation you suggest for a bilateral pleural effusion? Investigations will be according to the clinical scenario, but we try to diagnose whether this is heart failure, chronic liver disease, or nephrotic syndrome. So we have to go for ECG, echocardiogram, urine routine and microscopic examination, serum creatinine, and finally we have to go for the ultrasonogram of hepatobiliary system to look for the features of chronic liver disease. So we have to go for urine examination, liver function test, and echocardiogram. In short, in bilateral pleural effusion. Why? Because in bilateral pleural effusion, the cause is likely to be transudative, and the possible explanations, possible causes are heart failure, nephrotic syndrome, or chronic liver disease. So we will start do investigations to find them. Is it important to do pleural fluid examination in bilateral pleural effusion? Usually not. It is not informative because the cause is generalized. It is not localized in the pleural fluid. So to find the generalized cause, you rather go for more important investigations to detect those. Like for heart failure, you just go for echocardiogram. For chronic liver disease, you go for liver function test and ultrasonogram of liver. For nephrotic syndrome, you go for serum albumin and urine for protein or urine for routine and microscopic examination. So these are the things. Let's see a different case. This is the fourth case in this X-ray. So this is an X-ray chest, posterior anterior view, showing. Uh, just look at this opacity. It is also homogeneous, but the density is less than that of heart. So don't use the term dense homogeneous. Just tell this is homogeneous. So this is not dense. There is a homogeneous opacity in the uh, probably in the mid and lower zones of the left lung field. Okay, just look at the angles, the cardiophrenic and the postophrenic angles in the left side. These are clear. So this opacity has some difference from the pleural effusion we have discussed a bit before. What is this? This opacity, the density is less than that of heart. So this is homogeneous, but not dense homogeneous. Another thing is there is no crescentic upper border, no just effusion. And the angles, the costophrenic and cardiophrenic angles, these are clear. They are not obliterated. So this is something different. And this is actually a case of consolidation. So how consolidation differs from the pleural effusion? It differs. Firstly, it is not dense. It is homogeneous but not dense. Number two, the costophrenic and cardiophrenic angles, these are not obliterated. And finally, it has no upper border with the crescent shape. So these three things distinguishes consolidation from pleural effusion. So what is the most common cause of consolidation? This is pneumonia. So this is the consolidation of the left lung, and this is pneumonia. What is the cause? This is pneumonia. So then you will be asked, what are the common microorganisms? In Davidson, there is a big list. Don't try to go for everything. Just remember the three common bacteria that cause pneumonia. The most common cause is pneumococcus, that is the Streptococcus pneumoniae, then Mycoplasma pneumoniae, and finally Haemophilus influenzae. Just remember these three: Streptococcus pneumoniae, Mycoplasma pneumoniae, and Haemophilus influenzae. So what symptoms this patient may present with? You may be asked thereafter. The symptoms will be very short, over days, maximum 1 or 2 weeks, usually less than a week. Okay. So short history of high grade fever, then cough with purulent sputum and chest pain. So this patient will present with high grade fever, and the fever may have chills and rigor, and there will be cough with purulent sputum and pain in the left chest. So this particular patient had pneumonia in the left side, consolidation in the left side. So pain will be here in the left side, not in the right side. So this particular patient will have left-sided chest pain. So what will be the signs if you examine? The signs will be like that. In the left side of the chest, you will find the movement is restricted. So remember one thing, when you are asked about any description of unilateral lung lesions, remember one thing: whatever the lesion is, the chest movement and chest expansion will always be diminished. And except pneumothorax, the percussion note will always be dull. Okay, the site of lesion. So this is the left-sided lesion. So what we will find uh, in this patient, in the left side of the chest, the on inspection, the chest movement is restricted. On palpation, the chest expansion is reduced. The vocal fremitus will be absent. On percussion, the percussion note will be dull. On auscultation, breath sound will be bronchial. This is important. In consolidation, breath sound is always bronchial, and vocal resonance is increased. Just see these things, that is vocal fremitus and vocal resonance, these are always increased. So these are actually same thing. When it is auscultated, this is resonance. When the same vibration is felt with the hand, it is fremitus. So what happens in consolidation? uh, Actually, in consolidation, the vocal fremitus and vocal resonance is increased, and breath sound is always bronchial. So it is fixed. To this, you will have an added sound, and that is crepitation. So, what is the expected finding? There will be very common expected findings, just like all unilateral lesions. That is, movement of the chest is restricted, the chest expansion is reduced, the vocal fremitus is increased. The percussion note will be dull, the breath sounds will be bronchial, there will be crepitations, and finally the vocal resonance will be increased. So remember, in only two conditions, the vocal fremitus, vocal resonance are increased, and the breath sound is bronchial. One is consolidation, another one is fibrosis. Okay. So fibrosis we are not going to discuss today. We are going to discuss consolidation only. In the next class we will be discussing on fibrosis. The difference is in fibrosis, the trachea is shifted to the site of the lesion. In consolidation, it is always central. So here we didn't mention the trachea because it is normally placed central. So what other investigations you will suggest in this patient? So with the meaning by other, that means the X-ray has already been done. It is supplied. So what other you can do? Others will be obviously complete blood count with ESR, the sputum for culture and blood culture. Remember, blood culture is quite a utility in the diagnosis of pneumonia, because sometimes sputum culture is confusing. It gives false impression because there is contamination from the commensals in the oral cavity. So it is blood culture that is often very useful. Okay. So what is the findings in complete blood count? Expected finding is polymorphonuclear leukocytosis. What is the importance of sputum and blood cultures in this case? To isolate the organism first of all, and also to know the antibiotic sensitivity, because the antibiotic resistance is very high nowadays. So you have to choose an antibiotic which is effective against the particular organism. So to know the sensitivity, you have to go for culture and sensitivity. So what is the importance of sputum and blood culture in pneumonia? The importance is isolation of organism and to know the antibiotic sensitivity. But this takes 2 to 3 days, uh, and in blood culture sometimes more than 1 week to get the antibiotic sensitivity better. And sometimes the culture is negative. So in such cases, you don't have to wait. You don't have time to wait. Actually, the condition will deteriorate. So usually the antibiotic is started before you get the results of the culture. Usually, a broad spectrum antibiotic is started, and it is changed if the culture sensitivity results shows that this is resistant. Then it is changed to uh, sensitive antibiotic. Okay, this is the way. So how to treat this case? We will treat the case with a proper antibiotic. A broad spectrum antibiotic is started initially, and then it can be changed later on depending on the culture sensitivity report. This is the way you can answer. So don't mention the name of any particular antibiotic unless you are asked about it. Because in Viva, you speak less, you speak step by step. That will actually uh, pass more time in your Viva board with more correct answers. So if you speak too fast, and if you give too many answers, even beyond that is asked, that will actually uh, finish, that will actually make your the capacity of answer finished earlier. Okay. So let's then, if you are asked, don't tell the name of the antibiotic. Then if you are asked to tell, okay, tell me which antibiotic you can give initially. So nowadays it is chosen that moxifloxacin 400 milligram daily is the antibiotic of choice to be used initially. Okay. And in uncomplicated pneumonia, it is given orally for 1 week, and in complicated, that is severe pneumonia, it is given intravenously for 2 weeks. So it is moxifloxacin and given orally for 1 week for uncomplicated pneumonia, and The same thing is given intravenously for 2 weeks for severe pneumonia. So if the patient is pregnant, then what you will do? The patient, you may be asked for that. So this is a fluoroquinolones. Quinolones are contraindicated in pregnancy. Okay. So in such condition, the choice is amoxiclav. Okay. So amoxiclav can be used if the patient is pregnant. The same route, the same duration. Okay. Usually it is given 500 milligram amoxicillin with 125 milligram clavulanic acid combination, that is 500 plus 125 complication 8 hourly. And if the pneumonia is uncomplicated, give it orally for 1 week. If it is severe, give it intravenous for 2 weeks. But remember, if you get the sensitivity report later on and it shows that your antibiotic you have used is not sensitive, it is resistant, then choose a different one from the test report. Okay, fine. So what are the complications of pneumonia? It is often asked. The first complication is type 1 respiratory failure. I haven't mentioned it here. Okay. It's type 1 respiratory failure, the most important complication. That is why many pneumonia cases are needed to be treated in the intensive care unit for artificial ventilation, oxygen, with or without artificial ventilation. So after that comes the other complications, include septicemia, septic shock, multi-organ failure, pleural effusion, lung abscess, and bronchiectasis in long term. So if you are asked what are the complications of pneumonia, don't tell these four first. First of all, the most dreadful and the most important complication is type 1 respiratory failure. Then the second one is septicemia and septic shock with multi-organ failure. So these two are the most dangerous things. Apart from this dangerous two, uh, the patient may also develop pleural effusion, lung abscess, and in here the patient may also develop bronchiectasis. So what are the most dangerous complications? That is number one, type 1 respiratory failure, and number two, septicemia, septic shock, and multi-organ dysfunction. So there is another X-ray. In this X-ray, there is opacity. It occupies the upper part of the right lung. So truly speaking, if you count, it occupies the mainly the upper and partly the mid zone. So if you just tell it is the upper zone, it's not a problem. So the upper zone of the lung cell. So the cardiophrenic and costophrenic angles are clear. It is homogeneous. So just describe it like this. This is an X-ray chest posterior view showing a homogeneous opacity in the upper zone of right lung field. The right costophrenic and cardiophrenic angles are clear. Trachea is central. Then everything is normal. So my radiological diagram, don't tell everything is normal. You have to mention all the points in your exam. For shortage of time, I am telling it, okay? So my radiological diagnosis is consolidation of the right lung. Okay, this is consolidation of the right lung. So can you tell which lobe is involved here? Actually, we cannot. To know which lobe is involved, you have to do X-ray chest lateral view. From anterior posterior view, it is not possible to confirm the exact lobar location of the pneumonia consolidation. Another case, just look at it. This is an X-ray chest posterior anterior view showing a homogeneous opacity in the lower zone of the right lung field. And the right costophrenic and cardiophrenic angles are clear. The opacity is also adjacent to the heart. So this is a consolidation of the right lung. So just if you are asked whether you can tell which lobe is involved here, first of all you say that I want to see a lateral uh, view, right lateral view of chest X-ray in this patient to confirm which lobe is involved. But still, then if you are forced by the examiner that okay, you are given only this one, there is no right lateral view right now, so can you just guess? Yes, if the opacity is in the lower zone of the lung field, there is a way to guess. The way is If the opacity is adjacent to mainly to the heart, it is likely to be the right middle lobe, or in the left side, it is likely to be the lingula. And if the opacity is more adjacent to the diaphragm, it is likely to be the lower lobe in right or left. So here in this X-ray, the opacity is in more connected to the heart, more adjacent to the heart. So probably this is the right middle lobe consolidation. But still, you need an X-ray chest right lateral view here to confirm it. So don't tell the examiner that you are confident that this is a middle lobe consolidation. Just tell them that I want to see a lateral view. So after telling that, if examiner asks you that no, we don't have any lateral view right now, you have to guess from here. Then you tell, okay sir, in such condition, probably this is right middle lobe because the opacity is more adjacent to the heart. If it were a right lower lobe consolidation, then the opacity would have been more adjacent to the diaphragm. Okay. So this is called Silhouette sign. Silhouette means the shadow. Okay. This is the Silhouette sign. So what is Silhouette sign? Consolidation adjacent to the heart is located in the middle lobe of the right lung or lingula of the left lung. And consolidation adjacent to the diaphragm is located in the lower lobe. Just compare the case 4 and case 6 here. That is in the case 6, this case, both cases, just look at it. Okay. I think in both the cases, uh, here the opacity is more adjacent to the heart. Here the opacity is still more adjacent to the heart. So I think in the both cases, it is likely to be, this is obviously likely to be a middle lobe, and this one is also left lingular. Left lingular. So this is not a lower lobe consolidation. This is correctly to be a left lingular consolidation because the diaphragm is spared. Let's now get into a case. Okay, so it's not only the x-rays, you will have some scenarios given by the examiner. Just let's look at it. A 50-year-old gentleman, diabetic, got admitted with high grade fever, cough with purulent sputum and pain in the right chest for 1 week. So what is the likely diagnosis? What are the signs you expect, and what investigations you want to do? So if you are given straightforward, that is high fever, purulent sputum, chest pain, means pneumonia. So likely diagnosis is pneumonia. What are the signs? I will, don't tell all the signs in the first answer. Okay, just tell that I will have the signs of consolidation in the right chest. Then if you are asked, okay, what are the signs of consolidation? Then tell on inspection this, on palpation this, on percussion this, on auscultation this. Don't tell all the points from the very beginning. Okay, so it will actually help you passing the time. You just spread out your answer and give it step by step. Okay. And what investigations you want to do? So I want to do complete blood count with ESR, X-ray chest, and sputum culture, blood culture, like this. So now we get into our next case, and this is case 8. Just look at it. If you carefully look at the X-ray, we will see something abnormal in the upper zone of the left lung. So this opacity, which is not equal in all its parts, it is a non-homogeneous opacity, and as if it is like pieces of cottons. So this kind of opacity is commonly called patchy opacities. So there are patchy opacities in the upper zone of the left lung field. Everything else is normal. So this kind of opacity in our country is nothing but pulmonary tuberculosis. So you'll be asked then what are the symptoms you expect in this patient. There will be a long history over weeks, over months, long history of low grade fever with evening rise of temperature and night sweats, weight loss, cough, hemoptysis. Okay. This kind of history usually the patients give. What signs you expect in this case? Yes, it is very clear that the disease is located in the upper part of the left chest. So when you examine the chest, you will find some crepitations in the left upper chest. So I will find crepitations in the left upper chest. Usually tuberculosis mostly affect the upper lobes of the lungs. You know that because upper lobes of lungs are high in oxygen concentration. That helps in the growth of the tubercle bacilli. That is why tuberculosis is more common in the upper lobes. What other investigations you want to do? I want to do a blood count with ESR and sputum for AFB and gene expert. So what is expected finding in CBC? It is high ESR. What is gene expert? Okay, so I am telling this term since I was talking about the pleural effusion. Actually, gene expert is nothing but a PCR, a polymerase chain reaction that detects a particular DNA segments of the Mycobacterium tuberculosis. So it helps in the diagnosis of tuberculosis. One thing, in addition to it, it can detect the gene which can cause rifampicin resistance. So it can also detect any resistance against rifampicin. So that is why gene expert is superior to AFP staining, because the result takes almost same time, 2 hours, just like AFP staining. And in addition to that, the yield, that means the chance of being positive is much more higher than AFP staining. And finally, it gives an additional information. It not only indicates that this is tuberculosis, it also shows that this patient might have resistance to rifampicin. So uh, you can actually mm, go for different drug regimens for drug resistance tuberculosis in such patients. So that is why gene expert is now replacing acid fast bacilli staining, AFB staining in most of the situations. Okay. So why gene expert is superior to AFB staining? Because higher detection rate and resistance of rifampicin can be detected. Uh, it is often asked to judge your memory. It is how do the AFB look under microscope? Just tell that these are red rods, okay, rod-shaped bacteria with beads. So if you just tell that these are bacilli, that means rod-shaped, and these are red rod, that's good enough. So we advise tuberculosis culture? Not always. The answer is not commonly and routinely. But yes, when the other tests cannot detect tuberculosis, we can do it. And if we have to detect drug resistance tuberculosis, then we have to also do the culture sensitivity. So what media is used for culture, TB culture? We can conventionally we use Western Jensen media, and it takes 6 weeks for the growth to come. There is a liquid media called the Bactec Mycobacterium growth indicator tube, or just you can say Bactec media. Okay, it gives growth quicker, that is within 2 weeks. But for culture sensitivity, that is, it only gives the culture. But to see the sensitivity, the time required is double. So if you do the complete culture and sensitivity for Lowenstein Jensen media, it takes 3 months, that is 12 weeks. And for Bactec media, it takes 1 month. What are the first line anti-TB drugs? So you know that rifampicin, isoniazid, pyrazinamide, ethambutol, and streptomycin. But first four are used. The streptomycin is a reserved drug. Although it is a first line drug, it is reserved. You will be asked about the common side effects of anti-TB drugs. There are so many. Almost all the anti-TB drugs can cause hepatotoxicity. But remember, the particular things that is in rifampicin will cause uh, red discoloration of the secretion. That is, the urines will be red, the saliva will be red, the tears will even be red. So you have, but it is benign. It is just the metabolite of the drug excreted through these routes. Okay, so you have to counsel the patient about these things. Don't worry, this is very normal. It indicates that the drug is well absorbed from your gut, and it is well entered in your body to act on the bacteria. So just need to counsel the patient. But if the patient develops hepatotoxicity, then there are some other issues. Isoniazid, it can also cause polyneuropathy. Pyrazinamide, it can cause gout. Ethambutol can cause optic neuropathy. So these are very important. So all anti-TB drugs can cause hepatotoxicity. But in addition to that, rifampicin causes red discoloration of body secretions. Isoniazid causes peripheral neuropathy. Pyrazinamide causes gout, and ethambutol causes optic neuropathy. So it is often asked. So if someone is taking anti-TB, okay, before that, the very common questions, that is, what are the formulations of anti-TB drugs available in Bangladesh? Actually, examiners want to judge your practical exposure with this question. So if you are not even seen the practical drugs, you have to answer it. That is, in Bangladesh, most of the anti-TB drugs are supplied as fixed drug combinations. So there are two types of fixed drug combinations. One is 4-drug combination or 4-FDC. Another one is 2-drug combination or 2-FDC. So 4-FDC contains rifampicin, isoniazid, pyrazinamide, and ethambutol. 2-FDC contains rifampicin and isoniazid. But still, there is a limited supply of uh, single drugs, that is rifampicin, isoniazid, pyrazinamide, and ethambutol, and those are used in special situations. So now you will be asked how to treat the patient of this X-ray. You just tell, I know that you all have the answer, but there is a way to present the answer confidently. If you just tell in this way, that is category 1 anti-TB therapy with pyridoxine for 6 months. That is the best way. Okay. So category 1 anti-TB therapy for with pyridoxine for 6 weeks. So you will be asked, is pyridoxine an anti-TB drug? Answer is no. Then why you are using it? Actually, isoniazid causes peripheral neuropathy by causing by causing the deficiency of this pyridoxine. So you have to supply it from outside to prevent the deficiency and subsequent polyneuropathy. So uh, this pyridoxine is used the entire duration of anti-TB therapy to prevent isoniazid-induced polyneuropathy. So what is the category 1 anti-TB regimen? It is often asked. That is 4-FDC for 2 months followed by 2-FDC for 4 months. Okay, it is very easy. 4-FDC for 2 months followed by 2-FDC for 4 months. Total 6 months. Now what is the dose? I know it is a bit clumsy, but still the only thing from tuberculosis that is clumsy. So better you remember it. It depends on the body weight. If it is only for the adults, of course. If the body weight is 30 to 37 kg, 2 tablets daily. If the body weight is 38 to 54 kg, 3 tablets daily. If the body weight is 55 to 70 kg, 4 tabs daily. And if the body weight is more than 70 kg, then 5 tablets daily. What will be the dose of the pyridoxine? It is 20 milligram daily. Okay. Some author also use 25 milligram, but the standard dose is 20. So you may be asked, if someone has already developed polyneuropathy while on anti-TB drugs, what you will do? So in such cases, it is not 20 milligram. It is this 20 milligram is to prevent the polyneuropathy. But if already there is polyneuropathy because of the anti-TB therapy, because of the isoniazid, then the dose will be higher, and that is 100 milligram daily. But Usually it is 20 milligram to prevent it, but if it has already developed, that is the polyneuropathy, then you have to give it 100 milligram daily. It is also a very popular question, that is how to manage when someone develops jaundice on anti-TB drugs. So this answer I think everybody knows, but I have written here a very simple way to uh, say it. That is, first of all the anti-TB drugs should be stopped immediately, at least for the time being. Then the liver function test should be done to establish hepatotoxicity, and the test usually we do is serum bilirubin and SGPT. In our country, viral hepatitis is very common. So you have to exclude that this viral hepatitis whenever someone develops jaundice. So the viral markers, that is anti-HAV IgM, anti-HEV IgM, and HBsAg to be done to exclude viral hepatitis. So first of all, stop the drugs, then do the liver function test, and finally do the viral markers to exclude viral hepatitis. So when viral hepatitis is excluded, these viral markers come out negative, then it is definitely drug-induced hepatitis, drug-induced hepatotoxicity. So now what you will do, you will repeat the liver function tests after 1 week, then after 2 weeks. So whenever the liver function tests become normal, you can restart the anti-TB drugs. But it is better now to restart the drug one by one and start at a lower dose and then go to the higher dose. So by this you can detect the drug that is causing the hepatotoxicity. So if you can detect it, that is the jaundice reappears after introduction of a particular drug, then you can remove that drugs from the list and you can add some other drugs, or you can go for longer regimen with the fewer drugs. Okay. So this is the way. So the anti-TB should be started when liver function tests become normal. The drugs should be starting at a lower dose and gradually increase. This is another question. What is MDR-TB? Multi-drug. So the answer is very simple. That is tuberculosis to rifampicin and isoniazid. Just to remember. And then another term is what is extended TB. That is what is extended drug-resistant TB. So this is the way. So okay, fine. So is it clear now, Dr. Riyad? Are you still listening? Okay, I think I should carry on. So the extended drug-resistant tuberculosis, actually, it means that it is resistance to rifampicin and isoniazid, just like MDR-TB. In addition, it has resistance to two other group of drugs. One is the quinolones, and another one is injectable second-line drug. So these second-line drugs, these are used for MDR-TB. Okay, so XDR is more resistant than MDR. That is, it is like MDR, it is resistant to rifampicin and isoniazid. But in addition, it is also resistant to some other second-line drugs used in MDR-TB, like fluoroquinolones or injectable drugs. So another very popular question: organs where TB cannot occur. Conventionally, the 5 organs, that is skeletal muscles, smooth muscles, thyroid, pancreas, and thymus. Organs where TB occurs more frequently. Number 1 is lung. Then after lung, it is pleura, lymph nodes, intestine, bones, CNS. So pleural tuberculosis is considered pulmonary, extrapulmonary tuberculosis. Okay, pleural tuberculosis is not pulmonary tuberculosis. Here is a case, that is a 35-year lady attended the outpatient with low-grade fever, weight loss and cough for 3 months. So mm, so what is the most likely diagnosis? What investigation you want to advise and how to treat this patient? So the most likely diagnosis is tuberculosis, obviously, low fever, weight loss, cough. In our country is tuberculosis. So what investigations? Then complete blood count with ESR, X-ray chest, sputum for AFP and gene expert. How to treat this patient? Same answer. That is category 1 anti-TB therapy with pyridoxine for 6 months. Okay. So answer will be like this. Now look at this. So this case, actually there are multiple shadows all over the both lungs. In fact, the heart is almost obscured. So these shadows are like seeds. This is called a miliary shadow. So there are multiple miliary shadows in all zones of both lung fields. This is called biliary tuberculosis. So this is a form of very severe tuberculosis which spreads to different organs through blood and lymphatic vessels. So the blood vessels and lymphatic vessels. This is a very severe form of tuberculosis called biliary tuberculosis. Usually in biliary tuberculosis, there will be some sign symptoms spread all over the body. So you'll be asked, what are the features you can expect apart from the respiratory signs? The respiratory sign is quite obvious in this patient. That is, there will be widespread crepitations in both lungs. Apart from this, there will be hepatosplenomegaly and choroidal tubercle. This is not retinal. This is choroidal tubercle and ophthalmoplegia. Okay, so correct it. This is not retinal tubercle. This is choroidal tubercle. If we do ophthalmoscopic examination, so what will be the Monto test result in uh, biliary tuberculosis? So Monto test, actually it is not diagnostic of tuberculosis. It indicates previous exposure to Mycobacterium tuberculosis. Monto test is positive when someone is all vaccinated. So if there is no tuberculosis, it can also be positive. It is not commonly done to confirm the diagnosis of tuberculosis. But we often do Monto test when other evidence of tuberculosis is lacking. So to increase our evidence of tuberculosis, sometimes we do Monto test as diagnostic test, but it is not a diagnostic test for tuberculosis. So this test, if you do it in biliary tuberculosis, it is usually negative. Despite there is tubercle bacilli in the body, it is negative. Why it is negative? Because in biliary tuberculosis there is severe immunosuppression, and Monto test will be is a immunological reaction to the tuberculin antigens. That is why tubercular proteins, and that is why Monto test is negative in biliary tuberculosis. So how it is treated? Biliary tuberculosis is treated the same way as pulmonary tuberculosis. So look at this X-ray. We have only 2 cases left, and this is our case number 11. Just look at here. There is a round opacity, round lesion actually, and this round lesion has 2 parts: the lower opaque part and upper black part. So we can tell that there is a round opacity with horizontal fluid level, and the 2 parts are divided by a horizontal line. So this is the classical X-ray of lung abscess. So there is a horizontal, rounded lesion in the upper zone of the right lung field with horizontal air fluid level. So this is an X-ray of lung abscess. So how do this patient will present to you? Actually, this is the next question that will be asked if you have given this X-ray. The presentation will be very short. That means over days, 2 weeks. Okay. A short history of high fever, purulent sputum, and chest pain. So just like pneumonia. So lung abscess and pneumonia have similar histories. Short history of high fever, chest pain, and purulent sputum. But in lung abscess, the sputum is usually very much foul smelling, okay, than the pneumonia. But still, if you tell the same symptoms of pneumonia, that is short history of high fever, chest pain, and purulent sputum, it's okay. On examination, what will be the finding? The findings will be same of that of pneumonia, same of that of consolidation. So I will find the signs of consolidation. But in addition to this, there will be clubbing of fingers and toes. Okay. So the in lung abscess, the symptoms are similar to pneumonia. The signs are similar to pneumonia when you examine the chest, and in addition to this, there is clubbing. So lung abscess is clinically quite similar to pneumonia, except one thing, that is in pneumonia there will be no clubbing. In lung abscess there will be clubbing. Okay. So what we'll expect in this signs? First of all, you will say that in general examination I expect clubbing. So if you say just say this, the examiner will be very happy. He may not want to hear the further findings. Okay, so start with this clubbing. But if it doesn't stop you, then go for the findings just like pneumonia. Okay. The chest movement is restricted on the right side. The chest expansion is reduced. Fremitus is increased. There will be dullness. Breath sound is bronchial. Vocal resonance is increased. There will be crepitation, just like consolidation. So what investigation you want to do? So we have already done X-ray, which is supplied here. So what else you want to do? I want to do a complete blood count with ESR and sputum for culture. Okay. To why sputum for culture? The same answer, to detect the organism and to see the sensitivity pattern. So how to treat? The treatment of lung abscess includes antibiotics, and here the antibiotics are long, usually for 6 weeks, and postural drainage of the abscess. So it does not require a incision uh, to drain lung abscess. Actually, it is a maneuver. Usually the head is kept a level lower than the chest, and then the person is asked to cough vigorously, and there is hitting the back of the chest with the uh, fist of another person. So it will dislodge the sputum from the abscess cavity and will aid its coming out through the mouth. This is called postural drainage. So this postural drainage is a very important in removing a large amount of sputum, which happens in lung abscess and bronchiectasis. So here is a case: a 55-year-old diabetic man presented with high-grade fever, cough with profuse foul-smelling sputum, and pain in the right chest for 1 month. There was clubbing. Just look at this. Everything is like pneumonia, but we have a clubbing in addition. So everything like pneumonia, but there is a clubbing. This is lung abscess. What is the diagnosis? Lung abscess. What investigation you want to do? CBC, ESR, sputum for culture, uh, and of course X-ray chest. How to treat? Prolonged antibiotic, usually for 6 weeks, and postural drainage. So in this patient, there is a tricky thing, that is he's a diabetic man. So you have to also check the glycemic control. So if you do not do blood glucose and hemoglobin A1C, you cannot actually see how much, how good the diabetic control is. So you have to good glycemic control is also a part of the treatment of this particular patient. So this is the tricky thing in such questions. There's a diabetic patient with lung abscess. How to treat? Treatment of lung abscess and treatment of diabetes. So if you cannot control the blood glucose properly, the infection will not be removed even with the best of the antibiotic. So here the treatment has two parts: treatment of diabetes and treatment of lung abscess. Just like this: broad spectrum antibiotic, postural drainage, and good glycemic control. So here the last X-ray of today. Just look at it. It has changes in the both sides of the lungs. So if you carefully look at it, This is there are some shadows which has the shape of rings like this. So these rings are nothing but dilated bronchioles. So these kind of shadows, there is multiple ring shadows in both sides of both lungs. This is characteristic of a particular disorder which is called bronchiectasis. So if you are asked to describe this is an X-ray chest, posterior view showing multiple ring shadows in all the zones of both lung threads. Then describe just like the other things, that is costophrenic, cardiophrenic angles normal, trachea central, cardiac shadow, pulmonary vessels, bony thorax, soft tissue shadows are normal. So my diagnosis is bronchiectasis. So how bronchiectasis patients usually present? So this is the case of bronchiectasis X-ray. They usually present with a very long history. So very long history of uh, respiratory infections, bacterial infections, that is productive cough. The sputum is profuse, foul smelling, and maximal produced in the early morning. So this is the key. There is very long history of recurrent attacks of productive cough. The sputum is profuse, foul smelling, and maximally produced in the early morning. This is the classical feature of bronchiectasis. And there is hemoptysis in many patients. So in some patients of bronchiectasis, there will be only hemoptysis but no sputum production. We call them a dry bronchiectasis. Okay. So you may be asked, if someone has hemoptysis but there is no sputum production, can it still be bronchiectasis? Yes, it can be. It is called dry bronchiectasis. What is the sign? Again, in general examination, the sign is clubbing, and in chest examination, the typical sign is bilateral coarse basal crepitations. So bilateral basal crepitations, and the crepitations is very coarse. Okay. So what investigation, what are the causes of bronchiectasis? In our country, the main cause is tuberculosis, but still there are other causes possible. Those are pneumonia, bronchial carcinoma, and childhood measles. So mainly it is tuberculosis origin. So what other investigation you want to suggest? You have already done X-ray. But bronchiectasis is not diagnosed until a better imaging technique has been used, and that is high resolution CT scan of chest. So to confirm that these ring shadows are due to bronchiectasis, you have to do HRCT of chest. In addition, because there is infection, you have to go for CBC and ESR and sputum for culture, and also AFB and gene expert. Because most of the bronchiectasis originates from tuberculosis, you should also think that there could be active tuberculosis even in this bronchiectasis. So to detect such active tuberculosis, you have to go for the tuberculosis test, also, just like AFB and gene expert. Okay, so we have to do conventional culture to detect the bacteria, other bacteria, and we have to go for AFB and gene expert to detect mycobacterium in bronchiectasis. So how to treat? That is, it is treated by postural drainage and repeated courses of antibiotics. So there will be repeated infections and repeated courses of antibiotics. In some cases, when there is severe hemoptysis, not responding to any conservative therapy, the affected lobe can be resected. So this is surgical lobectomy of lung. Sometimes even the pneumonectomy can be done in severe hemoptysis in bronchiectasis patients. This is a scenario, that is a 30-year-old lady came with recurrent cough with profuse foul smelling sputum, most in the morning for 1 year. So that is profuse foul smelling sputum, and it occurs more in the morning. So this is a case of bronchiectasis. So if you are asked that what investigations you will do, I will confirm this with the help of X-ray chest, and finally with HRCT scan. I will also do complete blood count with ESR and sputum for culture, AFB, and gene expert. So how to treat this patient? This patient needs postural drainage and also repeated courses of antibiotics for active infections. That's all. And if there is any active tuberculosis, then I will also go for anti-TB therapy. So very simple answer. So I think today we took quite a long for discussing the Viva questions. So hopefully we'll see you next week, and the respiratory system is likely to end in our next classes. So I'll, with your permission, I want to take leave now. So all the best for the upcoming professional examination. So see you after 7 days. Until then, take care. Allah Hafiz. Thank you.